All right, we'll go ahead and get things started then. Welcome, everybody. Glad you could join us for our Learning Cafe today. Um, at the Center of Excellence and called Psychobabble 101, Understanding and Identifying Appropriate Psychotherapy for Children in Foster Care. We are very pleased to have our very own Dr. Caleb Corwin joining us today. Dr. Caleb Corwin, he is a clinical psychologist at the UT Graduate School of Medicine Center of Excellence for Children in State Custody. Caleb received his doctoral degree from Louisiana State University. Go Tigers. Caleb had completed his postdoctoral training at the Kennedy Krieger Institute at Johns Hopkins University and at Cherokee Health Systems. Caleb specializes in working with children and families and that have experienced trauma. He is currently working at the COE for Children in State Custody to help support dissemination of trauma-informed evidence-based care for children and families involved in the child welfare system. So without further ado, I'll transfer this over to Dr. Corwin.
All right, thanks. Thanks for the introduction, Drew. You did everything except for I'm going to do my peer pressure to everybody to turn on your camera. Yeah, just, I know some of you can't, some of you are eating lunch, so understand if you're not able to. But if you're able to, please turn on your camera. It's always nicer to see your smiling faces or your concerned stares than it is to stare at blank screens and assume I'm talking to no one. So thanks to everyone for joining us today. So today I wanted to do this talk because in talking with a lot of families and a lot of people who work with children who are in foster care, I became acutely aware that we use a lot of alphabet soup when we are talking about services for kiddos, and it's hard to navigate the different services provided. And so I wanted to talk to you a little bit about this today. I know that on some of these areas, I'm not going to be the most knowledgeable person in the world. And so, if you all have questions or things to add, I encourage you to do that in the chat, or I'm going to open for questions at the end. So please share that information. And some of you work for agencies that are going to provide some of these services that I discussed. So again, if you have information about how to hook a family up with these services and I don't talk about that, please share that in the chat, because I want people to understand these services, but also be able to access them. So, share that. We miss a little bit of that networking when we do this virtually. So please feel free to do that here. So today I want to, hopefully by the end of this talk, you'll be able to identify the need for behavioral health services for children who are in foster care, understand what mental health services are available and appropriate for children who are in state custody, learn how to identify evidence-based interventions, and learn how to request evidence-based interventions or talk to somebody about having someone receive those. Many of these statistics may not be shocking to the people on this call, but the statistics from 2020, which I think are probably going to go up for 2021 and 2022, is that there were a significant number across the state of Tennessee that were found to be victims of child maltreatment. A significant number of kiddos also continue to be in foster care and entered foster care, and we saw some increases in the number of children entering foster care during the past couple of years. So we're talking, as I talk about these services and who they apply to, I'm talking about a large group of children across the state that's ever evolving, right? We have kids who are exiting custody and entering custody at any given time. We know that for kiddos across the board, in custody or not in custody, about 25% of children aged 3 to 17 in the state of Tennessee have been diagnosed with a mental health concern, be that ADHD, depression, anxiety. We're seeing there's a significant number of mental health needs for all kiddos. But when we look specifically at children who are in state custody or involved with child welfare, we see that those rates unsurprisingly increase. Somewhere between 40 to 80% of children who are in foster care meet criteria for a mental health diagnosis. And I think anybody who works with children who are involved with state custody, they're aware of it. We know that a lot of these kids have a higher level of need and a higher level of need for behavioral health services. And so I want to talk a little bit about why that might be and why that comes to be. One of the things we see that trauma exposure is associated with a significant number of functional deficits and difficulties. We know, this is a chart from Dr. Nadine Burke-Harris and her group out in California. one of the studies that they did. But what they found is for kiddos who are identified as having a learning or behavioral problem, they are significantly more likely to have been exposed to 4 or more adverse childhood experiences, potentially traumatic events in their life. And that there's, I mean, you can see this is a pretty strong correlation here. The more you are exposed to this, the more likely you are to be identified as having a learning or behavioral health problem. When we see those kiddos come into custody, and we see, a lot of times they already come with a mental health diagnosis. And some of the most common mental health diagnoses we see are ADHD, we see bipolar disorder, we see depression, we're seeing an increase in kiddos who are diagnosed with autism. What we're often not accounting for with a lot of these kiddos is the significant impact that this trauma has in their mental health, on their overall mental health. And I share this Venn diagram first because I just love sharing a Venn diagram in any presentation I do. But second, because I think it really illustrates the point of we're seeing kiddos who are coming in with these diagnoses that don't adequately capture the impact of their trauma on what's going on. And we know that there's a significant overlap between these traditional diagnoses that kiddos have, ADHD, maybe not bipolar disorder, but depression, anxiety, those diagnoses, and trauma. And they're not always related, but that there is a significant percentage of overlap, and that considering that is a really important part of our job as advocates for these kiddos and as professionals serving these kiddos, is to understand how do we look at that overlap and how do we separate those things in order to identify the most appropriate services for them. We know that this is important because statistics have shown us that children that are in foster care are twice as likely to be diagnosed with PTSD than veterans who have engaged in combat. We know that this diagnosis of PTSD, while still probably underutilized for children because it wasn't written for children and there are a lot of problems there, but because it's not being utilized, we're missing that part of the conceptualization as we're talking about their care. And again, I want to highlight, I'm not saying that every kiddo in custody has PTSD. Please don't hear me saying that every kiddo in custody has PTSD. But I am saying for our kiddos who are in custody, we need to be considering the impact of trauma on their functioning. We know that trauma can impact multiple parts of their functioning. We've seen this, and I'm not going to go into it here in depth about the impact of trauma on the brain. There's some great talks out there. Dr. Hahn, Dr. Nadine Burke-Harris, there's some excellent ACE videos. We've done talks in the past. You can look on our YouTube channel and see other talks about the impacts of trauma. But we do know that these early life experiences, these repeated exposures to traumatic events, this complex trauma affects the way that the brain and the body develops for these kiddos. And so one of the most important things to understand is that by being exposed to this potentially being exposed to repeated traumatic events, that's shaping how they experience the world, and that's creating a unique set of circumstances that are going to require a specific form of treatment to address that and to understand that. If you have a child that has difficulty focusing and sitting still and paying attention because they have a family history of ADHD, they're going to respond to totally different interventions than a kid who has difficulty sitting still, focusing, and paying attention because they have a history of being physically abused and living in a neglectful environment for the past 10 years. And so we need to understand that so we can better inform their treatment plan. One of the first things that we need to do is when we have a kiddo come in to look for services, or we've identified a need for services, we need to identify what services are appropriate. And we often get asked a certain question for how we're going to figure that out. And one of the ways I like to think about this and differentiating this is if you were to go to the ocean, go to the beach, and you wanted to go into the ocean to see fish, what would be the easiest way to do that? Right? I'm not going to make people unmute because it's going to take a long time. But if we did that, right, the simplest way to go into the ocean to see fish, right, would be to go snorkeling. Right? It's low cost, easy accessibility, right? You grab your snorkel, you grab your fins, you can go in and you can see fish, right? And then the question becomes like, well, why wouldn't you go snorkeling? Well, you don't go snorkeling because snorkeling is pretty intensive. You have to train and it requires a lot of equipment. when we have kiddos, when kiddos come into custody, oftentimes the question is, okay, do they need a mental health assessment or a psychological exam? And oftentimes working in the Center of Excellence, we get asked to complete a psychological, can you do a psychological exam? I want to highlight this difference because most kiddos in custody, what they need is snorkeling, right? They need a mental health assessment. A mental health assessment is something that's readily available. It's something that can be completed by most mental health providers. Most of our therapists at community mental health agencies are doing a mental health assessment as part of their intake, right? They're taking a history, they're understanding what's going on, they're assessing what symptoms are going on, and they're coming to a working diagnosis. This can be used to assess ADHD, depression, anxiety, substance use disorders, trauma-related disorders. The majority of things that people are coming through the door for can be addressed with a mental health assessment, which isn't often thought of as something formal. It's more just thought of as the intake process. And again, this is something that's readily available, easily accessible, does not take a very long amount of time. And the clinicians that are providing this are often associated with continuums of services that they can readily then connect people to so that they can get the additional support that they need. I want to differentiate this from a psychological, which I think about far more as like scuba diving. It requires additional equipment, additional training. It is far more labor intensive. This is something that is not readily available. Anybody who's looking for a psychological evaluation, you may find that you run into a 3 to 12 to 15-month waiting list to get a psychological evaluation. And then once you have that evaluation done, you may have a clinician who does that evaluation where there's a 1 to 3 month turnaround, even after they've seen you and finished testing. So this is not something that's done quickly. And in general, we try to save this for specific instances. A psychological evaluation is necessary and useful in diagnosing things like cognitive deficits, learning disorders, psychosis, and in some instances, autism spectrum disorder. And I think about this like I think about snorkeling versus scuba diving. You can see most fish in the ocean by snorkeling. You do not need to learn to scuba dive. There are a couple of fish in the sea that if you want to see them, you need to learn how to scuba dive. You're going to need to scuba dive if you want to see like manta rays or sharks or some of these things like up close and personal. But you're going to be able to see the majority of fish well, maybe not the majority, but a lot of the pretty fish in the ocean by snorkeling. And so a psychological is really only necessary if we have questions about what's their current cognitive ability? Do they have a psychotic disorder or not? Do they have a learning disorder? Or do we need to rule in or out an autism disorder? And again, a lot of these clinicians that provide psychological services are siloed. They work in independent agencies. They're not associated with a continuum. And so getting connected to services following this evaluation is often a lengthy process and less well set up. But let's say you do that and okay, we need services. There's a wide array of services that are available to kids who are associated, or who are in state custody, right? And you may have heard many of these acronyms, heard of many of these things. I'm going to talk about a lot of these things. We're going to go like a mile wide and an inch deep on a lot of this. But I want to highlight some of the things that oftentimes kiddos are qualifying for and are receiving. Tennessee Health Link is a service that's available to any recipient of PIN care. And it's really designed for our patients who are higher need, right? They have a demonstrated functional need. They have a severe persistent mental illness. They've had multiple hospitalizations or out-of-home placements. And really what this is care coordination. This is somebody on the team who joins the team to help kind of coordinate referrals, make sure people are getting places, make sure information is shared between different participants. This is something that is not a direct care like therapeutic service per se. It's a coordination of service in this instance. And there are different Tennessee Health Link providers across the state, right? Many of our community mental health agencies are also Tennessee Health Link providers and providing these services. A step up from that, if that wasn't enough, would be to receive CTT or continuous treatment. This is a more labor-intensive coordination of behavioral and medical providers. And this comes with some additional support. It's going to allow a consumer to have access to 24/7 crisis services. It's going to involve once a week, one-to-one, face-to-face contact to help coordinate those services. Again, this is not a clinical service per se. This is the coordination of service still at this point. Useful and necessary and helpful. But when we talk about CTT, we're talking about a service that is more of a kind of purely traditional case management service, where we are coordinating services among teams. The next portion of our alphabet soup is CCFT. We see a number of kiddos who receive CCFT, which is comprehensive child and family treatment. This is for kiddos who are at risk of an out-of-home placement and for who lower levels of care have not been appropriate. And this is staffed by a multidisciplinary team. If the kid is receiving CCFT, they have access to a case manager, nursing staff, psychiatry providers, as well as the team of providers that are supervised by a master's level clinician. This team is often providing 3 face-to-face contacts per week, with the goal being that 2 or 3 of those happen at home. Although I know on many teams, feasibly, a lot of those contacts end up happening at school, but we're multiple contacts per week for these kiddos. These are kiddos who have often struggled with other levels of care. They're not responded well to once a week therapy, and we're saying they need something individual, something more intensive. I will highlight here, though, that this, while it is a more therapeutic service, this is not a service that's delivered often by a licensed therapist. And it is a service that can occur at the same time as someone is receiving individual or family therapy. So getting this does not exclude somebody from receiving an individual therapy. And oftentimes, in my experience, it works best when those things happen concurrently and the individual therapist is able to coordinate with the CCFT team to have the person in the home working in concert with a treatment plan that's been developed by their clinician. And this service typically lasts for 3 to 6 months, although I've seen it renewed for families when there's a continued or highlighted need. And oftentimes we'll see episodes of this care where it will happen for 3 to 6 months, and then things will plateau or improve, and then it will come back in later on. The step above that, and kind of we're thinking hierarchically here about each of these, but a step above that might be an intensive outpatient program. You'll hear these referred to as IOP. IOP programs are traditionally thought of as substance use programming, although we've seen recently, and I know there are a couple in the area now, of mental health IOP, intensive outpatient groups. And these groups are intended to be just a more intensive level of service. Oftentimes, these will include individual and group components, and there'll be multiple children at the same or adolescents at the same time meeting together for three to 5 days a week for 3 to 4 hours a day. So it's a pretty big commitment to a family or a child to participate in these services. The benefit being it's a more intensive level of services. Oftentimes, these groups are working on providing psychoeducation related to mental health, mental illness. They're working to help the kiddos to develop appropriate coping skills. They're processing and discussing typical conflicts and barriers. They're working to develop mood stabilization strategies. They're doing a lot of good things in a more intensive format. And so this is something that, I can't think off the top of my head. I know if anybody knows of the programs in the area that are offering IOP, I know that there's a mental health IOP available through, I believe, Next Steps Behavioral Health has one. There's another one that was somewhere recently that I'm blanking on the name of the agency that provides it. But if anybody knows, please enter those in the chat, because I think the other useful thing of this is helping people understand how to access these services. Oh, Florence, somebody typed in Florence Crittenson has one as well. The next step, and I think, again, thinking about this stepwise, the next step might be hospitalization and crisis stabilization. So this is to address an acute behavioral health need. And so someone who's not able to be stabilized in the moment in the community may require hospitalization or crisis stabilization. Oftentimes, this is being indicated or filtered to through our mobile crisis, so contacting mobile crisis, and they will help you to determine which of these is appropriate. But recently, Helen Ross McNabb established the Crisis Stabilization Unit at Children's Hospital, which I think is an excellent resource that's now available to us here at East Tennessee. Crisis stabilization unit is intended to be a short-term stabilization. It's intended to be 1 to 3 days. And if someone is not able to be stabilized during 1 to 3 days, they will facilitate a more intensive psychiatric hospitalization. And often psychiatric hospitalizations are lasting anywhere from 3 to 6 days. I want to highlight here that the goal of hospitalization or a CSU stay is stabilization. These are to help return somebody back to the community. It's not expected that somebody with depression or with a trauma history of PTSD is going to go for a CSU stay or a psychiatric hospitalization and come out after 7 days and be fine and not need treatment. This is to make sure that some safety concerns are addressed so that they can go back to the treatment plan that was in place before, or so they can, for the first time, be established with a treatment plan to help address their longer term, more significant needs. In a hospital or crisis stabilization setting, you'll see our kiddos are usually getting access to a psychiatry provider to adjust or start medication, case management services to facilitate aftercare, individual and group therapy, and most of the time, all of the availability that may depend on the setting. And all of these things may vary based on where you receive this service, because different locations, different agencies are able to provide or do provide different services here. The next level would be residential treatment. Typically, residential treatment is reserved for kiddos who potentially have multiple psychiatric stays. They've been through CCFT multiple times and continue to have significant safety concerns in less restrictive settings. Residential treatment should never be thought of as a frontline treatment. It's not an ideal placement for somebody unless they have those continued safety concerns and have tried multiple other levels prior to that. Really, our residential settings vary in the services they offer, and within DCS they're kind of considered level 2 to level 4, although we have some kind of level 1-ish, which is more like a group home where there's not necessarily a therapeutic service involved. It's more of a kind of a group home setting, all the way up to level 4, which is going to be more of your locked facility where you've got kind of all the services on site, where they're going to have access to nursing, individual therapy, group therapy, psychiatry, case management. They're going to go to school in that setting. And as you can imagine, some of these environments end up being chaotic some of the time because you have a lot of kiddos who have high level of needs in the same place. And so some of those settings, because of the level of chaos, that can occur from all those kids in the same place, we want to reserve it for our kiddos who really need it, and trying to use this only as this higher level of care when needed. The other thing about residential care is it's long term. It's rare for me to see many kiddos who have stays in residential treatment shorter than 6 months, although some kiddos will exit after about 3, but 6 to 12 months is a more typical stay for residential treatment. And again, they're going to receive individual therapy there, but I'm going to talk about individual therapy a lot more here in a minute. What that individual therapy looks like is going to vary drastically. And so I'm going to encourage you to advocate for the type of care that a kiddo receives. If you know a kid in custody who's attending a residential facility, asking questions and talking about what those services look like, because I'll argue that not every service is necessarily created equal in this situation. Oh. We will also want to understand psychiatry is something that is a service available to kiddos who are in residential care. I want to be careful when I talk about psychiatry here for a minute, because we know that while psychiatry can be a really important and beneficial part of a kid's treatment plan, behavioral health treatment plan, we know that children who are in state custody are medicated at a much higher rate, and they're much more likely to receive polypharmacy than other kiddos. Oftentimes, the goal of psychiatry is to address and improve functioning and reduce symptoms. The problem is not all of our psychiatry providers and not all of our treatment teams are well educated in the impact of trauma. And if you assume that a symptom is unrelated to trauma, you may continue to try to medicate it with different things without getting to the root cause of that difficulty. And I say this to say, I encourage everyone, if you have a child who's in state custody who is receiving psychiatry, just to advocate for asking the question, is this necessary? Are we also simultaneously addressing trauma? For kiddos in custody, oftentimes psychiatry can end up being a necessary tool to allow a child symptom relief in order to more appropriately engage in the other therapeutic services that they are receiving. And it's well used as an adjunct rather than as a sole intervention. I caution anybody using this as the sole intervention for any kiddo who's in custody, because we know that the likelihood that they are going to benefit from that intervention is pretty low, and the likelihood that they're going to end up over medicated if they're only receiving psychiatry as their only behavioral health intervention is pretty high. A lot of people talk about evidence-based treatment. And so I'm going to talk more about individual therapy and what that looks like. But I want to talk and set the stage first about what evidence-based treatment is, because there's a specific definition for what constitutes an evidence-based treatment. And evidence-based treatment isn't just something that, oh, I know this worked with my former patients, right? It's worked for all my patients, so it's worked for you, so it's evidence-based. It's also not something that, oh, I read a book about it, and it's in a book, so it's evidence-based. There are books written about lots of things that are not evidence-based. Evidence-based means that it went through rigorous steps of testing. First, somebody had the idea based on previous findings. They said, oh, this is kind of like that other treatment, but I'm altering it to make it work for this group of people or in this way. Then they do a pilot study. They say, okay, well, let me get a couple of patients together and just see if this works with it. And then they say, okay, we're going to do a randomized control trial. We're going to randomly assign you to either get the treatment or get some other treatment. And we're not going to pick and choose, and we're not going to know who goes into what group, and we're going to see who gets better. And then the treatment group got better consistently. So, okay, it worked there. And now, before we're evidence-based, I still need some other group who did not develop this treatment, who's not financially invested in this treatment working, to come and do a randomized clinical trial to show that it works. We have multiple steps here to get to where we have confidence that something is going to work for other people. And so again, if something is evidence-based, anybody should be able to show you what that evidence is. You should be able to ask, oh, it's an evidence-based intervention. Would you mind sharing with me the information that supports this intervention? And any clinician providing that intervention should have knowledge enough to know how to access it. And if they don't, a red flag should go up for you. And I encourage you to, ask more questions, and we'll talk about what those questions might be here in a little bit. But we know that there are a lot of good evidence-based treatments out there for children who are in custody. A resource that I encourage everybody to write down and look at, if you have not already accessed this, is the California Evidence-Based Clearinghouse for Child Welfare. This is a phenomenal resource that I hope never disappears, because I use this all the time when I'm hearing about, oh, they're receiving whatever therapy of the week might be going on. And I'll look in here and see, okay, well, what is the evidence? And this will even link you to the studies that support that. And so you can read some of those yourself, but in addition to showing whether or not there's evidence, it shows whether or not there's evidence specifically for children who are involved with child welfare. And I think that that's relevant because we know that kiddos who are in child welfare have specific needs and that they represent a different population. And so we want to make sure people are educated about it. We want to make sure that have that special education, because just like if you went to the most decorated foot surgeon in the world for your chest pain and gave them your chest x-ray, yes, they went to medical school, but you are not going to get the highest quality cardiovascular care from a foot surgeon. That doesn't mean they're not a good foot surgeon. That doesn't mean they're not a good doctor. It just means they're not a good doctor for heart problems. And the same thing is true when we're talking about trauma. It's important to know that the clinician that's providing services to a child who's in need of trauma services is trained to do that. It's not to say that somebody who's not trained in trauma services isn't a good clinician, but it might mean that they're not a good clinician for a child who has a trauma history and whose symptoms are related to that trauma history. And so I want to encourage everybody to think about the providers who you're working with, who are providing these services to kiddos in custody, and whether or not they have that experience and expertise. And I'll tell you, part of what we do is train clinicians to work with children in state custody. And so I know there are a lot of providers out there who do have this knowledge and this ability. There are a number of people out there, and trauma trainings are becoming increasingly popular. And so there are people who are seeking this training out on their own. These experts exist in our community. We just want to make sure that, especially for our kiddos who are most at risk, our kiddos who are in custody, that they're seeing people who are qualified to work with them. We want to do this first and foremost because we know that being exposed to a trauma does not in and of itself mean you have a trauma-related diagnosis. Just having experienced child physical abuse does not mean you get a PTSD diagnosis. And we need clinicians who are aware of that. We need to understand that while it's important to include that abuse exposure as part of the conceptualization, we don't always include it diagnostically. And we want clinicians who are adequately trained to complete trauma assessment to identify whether or not that exposure is related to an appropriate diagnosis. Trauma assessment looks at potential symptoms of PTSD. We're looking for things like hypervigilance, avoidance, intrusive thought, re-experiencing of the event. We're trying to understand whether or not that inattention is due to they're just staring at squirrels out the window or they're reliving the worst day of their life over and over again in their mind. And that distinction is clinically important. And we need clinicians who are going to ask those questions and know how to ask those questions and then know what to do with the answers that they get from those questions. And I would argue that one of the things for any good trauma trained therapist is they're going to have the ability to do a trauma assessment. And I don't think it's outside, of the realm of what's appropriate to ask if you have a kiddo who is in custody, who's in state custody, who's receiving behavioral health services, to ask their clinician to complete a trauma assessment or ask if one has been completed and ask how that's being utilized to plan treatment. Because any clinician who's been well trained in any of the evidence-based trauma treatment is going to have an ability to talk to you about that and is going to be using this assessment plan for. I could have another really good Venn diagram in here, but I haven't made it yet. So opportunities for the future to include a second Venn diagram, which would really knock this presentation up a notch or two. But where I haven't included it is we know that there are a variety of evidence-based trauma treatments that are appropriate for kiddos who are in custody. What has been done is the National Child Traumatic Stress Network and other trauma experts have looked at, if we look at all of these evidence-based trauma-informed treatments, where's the overlap? What do they have in common? And where we see that overlap on the Venn diagram of those evidence-based treatments are in these areas. It's been identified that evidence-based trauma-informed psychotherapies all have a psychoeducational component. They all have a piece where you're educating the child and typically also the family, the foster family, the kinship placement of the bio family, on what are common PTSD symptoms, understanding how that hypervigilance plays a role, helping them to make sense of those intrusive thoughts, letting them know that they're not alone. These are common reactions to these traumatic exposures. They're also, all of those treatments are very explicit in talking about treatment options. They outline, here's what treatment's going to look like. This is not going to be a mystical process where you just come along for the ride. I'm going to educate you from the outset about what we're going to do, and we're going to engage in this process eyes wide open from the outset. Each of these evidence-based treatments also was found to include an emotion regulation, where we're going to teach skills about how to understand, identify your emotions, and learning different ways to cope with it. They all had some component of imaginal exposure. We're going to talk about trauma. We're going to talk about potentially the trauma that you have lived through, and we're going to expose you to the reminders of that over and over again in an imagined format, because we know that that imaginal exposure for most of our trauma treatments is one of the most active ingredients. That's what leads to some of the most significant clinical changes, is through that exposure process, which for pretty much all of the treatments I can think of is a gradual exposure process. It's not as if we're going to talk about this all in the first session. We're going to work our way up there, but all the while we're doing miniature exposures along the way. Many of the treatments also include an in vivo exposure, where you're doing, this can be a variety of things, but if a kiddo is fearful of a doorbell because the alarms went off when somebody broke into their house and that's the trauma that's really challenging for them, then you're going to do in vivo exposure to help them practice experiencing that stimulus, that doorbell over and over and over again, to help them acclimate or habituate to that stimulus instead of avoiding it and continuing to have that hypervigilance. in response to that. These treatments also included a cognitive processing component, learning how to think, notice your thoughts, think about your thoughts, challenge your thoughts. And they also include a problem-solving component, teaching people how to think through how their trauma plays a role in what's going on, and teaching them the skills for how to solve problems logically and kind of consider their emotions, but step away from those while making decisions going forward. If we think about these, there are a number of these that fall into this category of evidence-based trauma-informed treatments, but I'm going to really focus on one, but I want to highlight three. The three that are most readily available in our area here in East Tennessee. We know that we have child-parent psychotherapy, CPP, which is pretty available in our area. We also have EMDR, which is eye movement desensitization and reprocessing. And then we have TSCBT, trauma-focused cognitive behavior therapy. These are probably the three most prevalent evidence-based trauma-informed treatments available in our area. They're available from multiple different providers. I was considering giving you a list of people who provide these, but I was worried I was going to leave too many people off. You know, there are people who are doing this who I might end up leaving off the list. But I will say, you know, if you're looking for a provider in one of these areas, you know, you can contact us and we can help you to locate that. Sorry, Drew. But if you need that service, but you also, if somebody provides that service in our area, I encourage you to, you know, share in the chat, you know, ways to connect with agencies that are providing these services, because we know that these interventions have been vetted. They've gone through that rigorous process. They've had the randomized clinical trials by multiple places. And so we want people receiving those best practices as much as possible. I'm going to dig in a little deeper to TFCBT. Full disclosure, my own bias is the one I'm most partial to, and it's not totally because it has the most evidence of all of these, but that does play a role. But TFCBT is an excellent intervention that's relevant for kids ages 3 to 18, right? So there's a wide age range for whom this is appropriate. TFCBT is also intended to be more of a family intervention. This is not an intervention where a kiddo meets one-on-one with a clinician and then comes back out to the car and says therapy was great. It's intended to be with a therapist that's also going to work with the family member to educate them along the way with each step and keep them involved so that they can do this work at home in support of what's happening in the office. We know that there's robust evidence that this can be helpful in reducing behavioral problems, that this is reducing anxiety and post-traumatic stress symptoms, and that this is improving and stabilizing placement, you know, when kiddos are able to reduce those symptoms. As you can see, what I've listed here on the slide, these are the components of TFCBT, which are not hidden from participant, you know, or a patient. You know, this is explicitly discussed from the outset of treatment that we are going to go through these different stages. And each of these stages map on pretty clearly to what the National Child Traumatic Stress Network says are the common elements of effective evidence-based treatment. So with TFCBT, there's a psychoeducational component along with parents to working with the caregivers as well as with the child to understand what trauma is and how it's impacted their life. There's also, you know, potentially meeting with that parent to talk about behavior management strategies, because we know that so often the kiddos that are brought in for services who are in custody aren't brought in because of their trauma history. They're brought in because of the behavior they display as a result of their trauma history and the way that they're trying to communicate that trauma history to us. And so we're working with the parent to problem solve and support them in addressing things. We're talking to them about how trauma affects their bodies and how to help relax their bodies in response to that physiological arousal. We're talking to them about the emotional component, affective expression and modulation, how to cope with those emotions. We're doing cognitive coping. We're teaching them how to think about their thoughts, how to notice unhealthy thoughts and how to challenge those. And then there's the trauma narrative and processing component, which is built up to because you're doing exposure and talking about trauma all the way up until that point. And then you're digging in and you're talking to them more specifically about their traumatic experiences and building their ability to tolerate and discuss and process those events so that you can work through any unhelpful thoughts that may have resulted from that, such as, if I'd only behaved better, he wouldn't have hit me. Or if I wouldn't have said that or looked that way, then that traumatic event wouldn't have happened, right? We're trying to help process and challenge those unhelpful cognitions related to that trauma history. And then we're doing in vivo exposure, potentially, doing these conjoint sessions where we're sharing this information again with the caregivers when necessary and when appropriate. And then talking about enhancing future safety and talking about planning for, okay, what do we do to avoid, to recognize if there's a potentially dangerous situation coming up again in the future, and how do we help you kind of play an active role in that, having lived through that. But again, this is this practice acronym. And I would say, if you have a clinician who's saying they're providing trauma-focused cognitive behavior therapy, my first question usually is, that's great, I'm so glad to hear that. Where are you in the model? Which part are you in? Because any TFCBT trained clinician should be able to tell you, oh, we're doing relaxation right now. We just finished psychoeducation, we're doing relaxation. Or, we just getting started on the trauma area. Now, I will tell you, this doesn't always go, it doesn't always spell practice. Sometimes you're doing other components, first. You might do affect expression before relaxation, or you might do in vivo before another component, right? Some of these things may be jumbled or hop back up and forth, but any clinician who's providing this evidence-based treatment should be able to tell you where they are. And again, that's the benefit of receiving an evidence-based treatment and advocating for an evidence-based treatment, is because there's not mystery to it. There's a clear and concise way to communicate that. I'm less familiar with EMDR, but I know there's a manual for EMDR. And if I was talking to a clinician who is providing, I'd say, well, where are you in the process? And they should be able to explain to me where in that process they are with treatment. With CPP, I could say, which phase of CPP are you in? And they should be able to explain that to me. Because these evidence-based treatments are manualized, and there is a consistent delivery that we know is effective for these kiddos, and we want them to receive the highest quality care. And so I encourage people to ask these questions to the clinician serving kids, because we want to make sure we're advocating for them to receive the best treatments that they can. Some of the questions that might be helpful to ask a provider is, when you first, from the outset, from the intake, is potentially to ask, do you provide trauma-specific or trauma-informed therapy? And then to follow up and ask, okay, you do, how do you determine if a kiddo needs trauma-specific therapy? The answer that I'm looking for there is, I do a trauma assessment, and my trauma assessment indicates whether or not a kiddo actually needs this evidence-based trauma treatment or not. Because again, not every kid who's experienced trauma and not every kid who's in state custody needs TFCBT or CPP or EMDR. A higher number of them do than the general population, but not all of them. I would then ask, how familiar are you with evidence-based treatment models and designed for children with trauma-related symptoms? And they should be able to tell me. And whatever treatment they tell me, they should be willing and able to give me information on that treatment. And I should be able to go to that California evidence-based clearinghouse and look it up. If it's not every treatment is in there, but I will say I haven't found a treatment that is evidence-based that's not in. So if it's not in there, that usually means it's just so new that there's not evidence for it yet. Which again, there are some new treatments that are promising, but I would want them to share with me why they thought it was going to work and where's the evidence that this is going to work. And honestly, if it's me, I know there are evidence-based treatments out there that are available that are tried and true. I'm more likely to advocate for a kiddo to get one of my tried and true interventions because I don't need something new and fancy. I know the old stuff. My next question might then be, how do you approach therapy with children and their families who've been impacted by trauma, regardless of whether or not they need a trauma-informed treatment? And I think that their answer there, I really want them to be thoughtful, right, about that, and thoughtful about the process and be able to outline a plan for me, that they include that there's a family component, because CPP, TFCBT, EMDR all include some caregiver involvement, some caregiver component when done in the way that it was when it received that evidence. And they should be able to, without a doubt, describe you a typical course of therapy. If they struggle to, well, we'll figure it out as we go. If that's the answer, run. I'm really concerned with that answer because I think that we want to make sure that these kiddos are working with clinicians that have a plan, you know? And if you're a clinician on this call, make sure you can answer all these questions because I think it's important for you to be able to provide answers to these questions confidently. Our kiddos need you to know what the plan is, and our families need to know what the plan is, and our kids need to know that there is a plan from the outset, because that helps to demystify and make this process a lot less scary. You know, I think getting effective trauma treatment is a huge part of what kiddos in custody need if they're experiencing trauma-related symptoms. That said, it is one part of what can help foster resilience for kiddos in custody. And I want to highlight that it is not the only thing, that it is one component. If you give a kiddo great evidence-based treatment, but none of the other factors supporting resilience are in place, we might not see the treatment gains that we hope to see. One of the things that consistently comes out in the literature time and time again, one of the biggest and most consistent predictors of resilience for anyone in response to a traumatic event is the presence of one positive, nurturing, supportive adult, right, relationship, whether that's with a caregiver, a teacher, a coach, a therapist, a case manager, a minister, whoever that might be. We know that these positive relationships are so critical for our kiddos. And so I encourage everybody to not discount that, because that, I would argue, is probably as important as the therapy, is supporting these positive relationships in the lives of our kiddos who are in the child welfare system and working with them to identify that. And that, you know, along that vein, kind of being strengths-based, right? What are the positive relationships that exist, and how can I advocate for those relationships continuing? Can I do something to support that? Because we want to maintain as many of the previous positive connections for these kiddos as possible. So many of our kiddos, I had a statistic before, we know that, I want to say it's like 40% of kiddos, 43% of children in Tennessee in 2020 had 2 or more foster placements during that year. These kids are not just moving into foster care, they're moving into foster care and then moving. And, you know, we see kids here who have, 5, 10, 15 foster placements. And how much instability is there? And so what can we do to maintain the previous connection? So maybe that kiddo couldn't live in that foster home anymore, but maybe they had a positive relationship with that caregiver that we can maintain. Maybe there's an aunt or an uncle in that child's life that was really important to them, who is appropriate, who might not be a placement resource, but could be a phone call resource. Maybe there's a sports team that, yes, it's an extra 10-minute drive, but we can keep that kid involved in that team because they had a good connection with that coach, or a youth group. Or maybe we can do something to advocate for that child staying in their school because they had a really good relationship with the teacher. And yes, that's an additional drive, but how meaningful is it going to be to that kid to maintain that relationship and those relationships? Because when we talk about school, we're talking about multiple relationships rather than having to change all of those relationships due to the foster placement. So I encourage advocating for those things in addition to advocating for these evidence-based trauma-informed therapies as well. All right, so that is all I have planned to talk about. What questions do people have? Or also, I'm sure there are services that I have missed, right? I tried to hit the things that I most commonly get questions about, or I explain and somebody says, oh, what's that? So I tried to include those services when I talked about this today. But are there services that people have questions about or know are available and have found helpful for kiddos in custody? You can chat or you can unmute. Both of those are acceptable formats for engaging. Oh, somebody has their hand up, which you're more than welcome. You can go ahead and unmute.
Hi, can you hear me?
Yes.
Hey, thanks so much for everything you said. I think this is really wonderful. I don't necessarily have a resource, but I have a question for you. So my name is Lisa Bolton, and I'm with an agency called Grow Free Tennessee. We work with youth who have experienced human trafficking. Yep. And oftentimes when we're working with kids who are in foster care, of course, like you talked about, they need specialized trauma treatment. And we do, actually, I guess that is a resource. We do offer that to kids and to adults. However, sometimes kids are maybe outside of our service region, and we really struggle to find someone who feels capable and is kind of willing to tackle a kiddo who has experienced trafficking, because it's a trauma that goes way past all traumas that we kind of talk about. And so my question to you was to ask, in those moments when we're not able to find someone who can specialize in trauma treatment of an individual who's experienced trafficking, is it still beneficial to find someone to put them in therapy, or does that do more harm than good? Because sometimes we do feel backed into a corner, like we really want them to be in therapy and we know that they need it, but we can't find anyone who really specializes in this. And so we just kind of find like the best that we can. Are we doing more harm than good in those moments?
I think that's an excellent question. And I mean, I can give you an answer. I imagine other people would give you other answers. But I think you have to do the best you can in so many of these situations, right? I mean, I think you ask the questions and you try to get somebody who has some experience or has experience as closely tied to that as possible, right? Like, I think if somebody doesn't have experience with, child sexual exploitation, right? But they did have experience with treating sexual abuse and evidence-based treatment for sexual abuse. I think that's a better fit than somebody who doesn't have experience with trauma, right? And I think that if you have a kiddo, especially when you have a kiddo who has an identified need for treatment, and especially if you have a kiddo who's motivated to engage in treatment, then I'm definitely advocating for like, let's do that, right? Let's get that going. And we've struggled historically in rural areas identifying some of these treatments, but now with our ability to do virtual, it's less of a barrier than it once was. And so I am often, we try to help people connect to services as well. Dr. Berkeley could talk, I'm sure, a lot about that. But we're finding more luck for some of our rural families by talking to our clinicians about, are you willing to offer virtual? Can you meet this need family by doing virtual? Because we know there's evidence for providing these trauma-informed services virtually, right? A lot of the developers for these evidence-based treatments have released guides on, here's how to do this via telehealth, because we had to.
Thank you so much for answering that.
Yeah.
Sorry. I would like to ask a question. Is there any specialized trauma therapy for children with sexual reactive behaviors, but who are now like 14, 15 years old?
Yeah, so there are treatments for children with problematic sexual behaviors. There's some offered throughout the state. As far as specific providers in our area, I'm not sure. I don't know, Drew, if you're aware. I know that one of the resources that we've often leaned on, and it's a residential treatment facility, which not every kid with problematic sexual behavior needs residential treatment. Please don't hear me say that. Most of them can be treated in an outpatient setting. But it's Stepping Stone. So Stepping Stone, oftentimes they complete a lot of our local psychosexual evaluations to determine the need for treatment in that area, as well as they provide treatment in a residential setting. I'm trying to think of blanking on.
I'm looking around the Nashville area, and I have called a number of therapists and resources in that area. Either they do not take TennCare insurance, or they are programs that are just getting started and there's long wait lists. So, I'm very concerned with this youth. It's starting to impact pretty much his daily life and school and everything. So,
So I will say, we've heard that concern kind of across the state, and I think there are some agencies gearing up to do that. Also, our Learning Cafe in January, I believe, Dr. Chris Dean, the director of our CV here in Knoxville, is going to be doing our Learning Cafe on youth with problematic sexual behavior. And so talking more about that in January more specifically, because there are some specific treatments for that, although they're not as widely available as it would be nice to have.
And I think that's some of the problem. The models that we train in are like TFCBT and PCIT and all the other good T's, but the dissemination for specific therapies treating sexual behavior problems is more minimal in this state. And so it more gets to finding individual therapists who are familiar, who have attended additional trainings that can adapt some of our trauma-focused treatments to those kiddos and to those behaviors. And the downside of that too is when we talk about agencies that take TennCare, they're usually larger agencies that don't necessarily have a feel for what individual clinicians might be more comfortable with. And so I hear you, and I'm validating the problem and finding they're out there. And certainly we keep our ears out for them in our followings as we work in kiddos in East Tennessee here. And so that's just, that is the greater difficulty here in finding help for those kiddos.
And I would give you the same answer that I gave to Lisa and that Lisa asked. You know, most of our clinicians who are trained in TFCBT are going to be fairly well poised to respond and work with most of our kiddos who have problematic sexual behavior, because most of our children with problematic sexual behavior, the problematic sexual behavior is a function of trauma history in most instances. Now that needs to be assessed, and I'm not going to make that assumption across the board, but getting them in with one of those clinicians is a likely avenue to getting them some support that's likely to be helpful and unlikely to be harmful.
Thank you so much.
Yeah, you're welcome. Any other questions? So I want to encourage everybody. I want to thank everybody for coming today. I really appreciate everybody's attendance and participation. In the chat is a link to the questionnaire, the survey for today. Please, please, please take time to fill that out. It's how, once you fill out that survey, you will get a link to your certificate for attendance today, which you can use for CEUs or whatever purpose you need to say you were here and you showed up and you participated. Also, please give us feedback on how this went today, any thoughts or suggestions you have. If there are topics that you are looking forward to hearing more information about in upcoming learning cafes, give us those suggestions there, because that's the information that we often use in order to help us plan these going forward. And then last but not least, next month, we're really fortunate to have a talk from two psychologists who are coming to us, well, virtually coming to us, from Vanderbilt, from the Treatment and Research Institute for Autism Spectrum Disorders at Vanderbilt University is Dr. Foster and Dr. Rodriguez. And they're going to talk to us about, do you have concerns about autism? Challenges, considerations, and resources when making a referral. They're really going to talk to us about what makes a good referral, what resources are available for kiddos who you suspect have autism, and I think that's going to be a really good talk. So I encourage all of you to join us next month.
And I have one final plug about a program that we're running here called Resource Parent Curriculums. This is our encore a little bit here. I'm going to put some flyers in here about this program, this group that we're going to be running soon. It's called Caring for Children Who Have Experienced Trauma. And it's open for foster parents, relative caregivers that are working with, or that have kids in the foster care system, or that have experienced trauma. And it's a 10-week program for them on some of the trauma-based principles, and it's a very good group format. We have several foster parents that come in, we share ideas, we talk about trauma. It's a really, time and time again, we've given this, foster parents have been thankful and grateful for receiving some of the talks and the insights and the education on trauma and the kids that they're working with. It's a free group. We do it virtually, so it's not necessary for them to show up. We're currently taking applications and have signups open. So I've included a brochure that talks a little bit more about the Resource Parent Curriculum, which the group is based on. And I've included a flyer as well, which has a link to the registration form. So please share that among your families that might be eligible. Again, it's for foster parents or relative caregivers of these kiddos who've experienced trauma. It's not necessarily meant for biological parents at this juncture. And so with all that, I want to thank everybody for coming out and thank Dr. Corwin for his time today. We look forward to seeing you guys at in January.
November.
Sorry, November's Learning Cafe. I was like, we were talking about January, got me. At November's Learning Cafe.